in Florida. So our patient today is a 44-year-old male who doesn't really have a history of allergies. He's got a little bit of hypertension. He's a bigger guy, so his BSA is 2.4. As far as the social and family history, he's married. There's no family history of any chronic diseases or anything like that. Occasionally he'll smoke. Doesn't use any alcohol other than socially or drug use. So what happened is he was taken to the emergency room because he had difficulty breathing, so shortness of breath. For the past 2 weeks, or 2 months, I'm sorry, he had pressure in his chest. The other thing, while they were doing a historical workup of him, is he was in a motor vehicle accident 3 weeks prior, but there really wasn't any history or any further workup done because of that motor vehicle accident. So right there, I'm sure you guys are thinking, something's going on here. Anyhow, at this outlying hospital, he was treated for a hypertensive crisis, so his blood pressure was up. When they did a CT, they did notice a large ascending aorta. And so since this hospital didn't deal with that type of procedures, they transferred him to where we were working at the time, a bigger institution. When he got there, they did an EKG, and they could see that he was in sinus tachycardia, and he also showed signs of left ventricular hypertrophy. If you look at the chest x-ray, you can definitely see, well, you can see the enlarged heart, and you can also see the atelectasis on both sides, as well as the pleural effusion. So you can kind of see, his diaphragm's at the lower half, but his heart is huge, and you see, the whiting out and stuff like that. So he definitely has some cardiomegaly going on, as well as some of that atelectasis and pleural effusion. So you guys are probably thinking, right, there's some type of leak going on here. Oops, go back. This was one of the echoes that we did, so, and it won't play here on this type of video screen. But when they did a TEE, he presented with acute diastolic heart failure. So his left side's not filling, obviously. That's why he's tachycardic, right? The other findings that he had was, his systolic function was normal, so he was contracting. They were normal sizes. He did have bilateral atrial enlargement. He also had AV trileaflet, mild to moderate aortic regurg. He had a proximal aortic root that had an intimal flap. His tricuspid valve was normal with a little bit of regurg there. They showed no pericardial effusion, and there was no intracardiac thrombi or vegetations. So he had a dissection that was noted here. So when they did a further CT at this institution that we were working at, they had marked dilatation of his ascending aorta. It was a 10 to 7 centimeter dilated in the arch there. His heart was obviously enlarged. He had moderate right pleural effusion with the atelectasis in the right lower lung and right middle lobe. And then also on the left side, he had pleural effusion both in the upper and lower lung lobes there. So when they did the assessment, they diagnosed him with a subacute chronic type 1 dissection. He had uncontrolled hypertension. He had the bilateral pleural effusion, as well as aortic mitral and tricuspid insufficiencies. And with this dissection, you can see that you get the regurg commonly, as well as renal complications because of the dissection. So the plan, this physician was going to do an ascending aortic arch debridement replacement with deep hypothermic circulatory arrest. So this is what we think is all typical. Preoperative assessment, other than the difficulty breathing and atelectasis and stuff like that, and the heart murmur and the large heart, everything else was pretty much normal in this young man. His vital signs and laboratories didn't really show anything significant other than hypertension and maybe a little bit of anemia here. So what we did, as we were getting ready to set up the circuit and everything, we used a Terumo RX25 Medtronic cardioplegia. It's just a straight system there, hemonetic cell saver and a hemoconcentrator. We prime with plasma light. We had heparin, mannitol, bicarb, Amicar, and albumin, we wrap and VAP these patients as well. And here's a picture of the setup. So pre-bypass, normal ACT, our gases really don't show much of anything significant with this patient. We did fem-fem bypass, so we cannulated femoral artery and venous with the 17 and 21 French Biomedicus that we heard about earlier today. Cardioplegia, we did retrograde with the Edwards, 14 French, and as well as osteal, and then we were venting the patient as well. They gave 30,000 for this young man. His ACT was 384. We don't use our HEPCON system, so we ended up giving another 10,000, and then our ACT was 501, right? So when we first went on, here's our calculated flows. So, we're going to cool down to 18 degrees, so we have flows from, 3 all the way up to 6 for this patient. So we start off at 100%, 4 liters of sweep, keep our means between 50 and 70, and we began cooling right away, and we run SIVO, and our ACT goals were greater than 480. So as soon as we initiated bypass, we got flows up to about 4.5 liters of flow, so this is just going on. FiO2 is at 100% for sweep. Our mean pressure is about 65. We're at 36.9 degrees. And we look, I don't know if some of us, we're seasoned perfusionists. We look at color difference, and if you're students out there, you should be learning to look at color difference, right? When we go on, make sure we're oxygenating the patient. So, of course, arterial is bright red, and of course, our venous is a little bit darker. And it could be subtle differences. And this is highlighted because this is going to be significant here as we start going on with this case. Our line pressures look good, and so we begin to cool. So after about a minute of going on, we typically see a pressure drop. We go on, we have higher pressures. Pressures start to drop. So we're flowing at 5 liters, we're increasing our flows, trying to get there. Our mean pressure drops to 45. We're still cooling. But when we look at the venous and arterial line, we see that they're both freaking bright red. It was like, so now it's like, anybody have any ideas? Bright red. I'm thinking, there was another perfusionist in there, and I'm like, are you seeing this? Are you seeing this? Yes. So we're trying to think, is shunting, what do we, what's going on here? Are we, too high sweeps, right? We're at 100%, stuff like that. Don't know. So we treat the pressure, obviously, right? Don't want a pressure of 45 because that's not in our goals. So we get the pressure back up, we're at 60. Still 5 liters of flow, nothing else has really changed. However, now our arterial is bright red and our venous line is no longer bright red, but the normal color. So we have that darker difference. And the only thing that's changed is what? Pressure, right? So now what are you thinking? Shunt maybe? There's something going on. Oops. 5 minutes. The other thing that we're starting to see now is all of a sudden we have a drop in pressure. So we're back down in the 40s again, and then we go back up. We're in the 60s, and then we're going back down. So we're constantly doing this roller coaster ride, right, with this pressure. So that's another significant thing. But here we go. Pressure drops again. Venous, bright red. Arterial, bright red. And so, and this is, 5 minutes of bypass. 7 minutes. Pressure's back up. Here we go again. We're still cooling. Not changing much of anything other than pressure and then the venous and arterial color differences. So, what would you guys do at this point? Anything? Anyone? Same thing, pressure drop. So we ended up saying, hey doc, we're seeing something kind of funny back here. First we have this yo-yo effect going on with the blood pressure, and 2, we're seeing this funky color difference. We're going bright red to this, that, and we couldn't figure it out, with our system. And I don't know if anybody out here that's brilliant that maybe has an idea might be able to figure it out. So 9 minutes, 10 minutes, same thing, this yo-yo effect. So the fluctuation continued. what we're noticing here is when the pressure dropped below 50, we saw that the venous would become bright red. So blood pressure drops, venous line bright freaking red. When it was above 50, it was normal, okay? You would think that if we had some type of a, shunt, left to right shunt, it would be venous, arterial blood to high pressure. When the pressure is higher, that it would go over to the, venous side or arterial side, venous side, and then cause it to be bright red. But we're seeing the opposite effect here. So what happened is we told the surgeon about this. He ended up taking a look at the heart. He felt a thrill in the right atrium, and he verified that there was a fistula. And with this fistula, it went from the ascending aorta to the right atrium of this patient. And even with the fistula, you would think higher pressure would drive that arterial blood over to the right side from the left to the right, but it wasn't. It was the actual opposite effect. So when the pressure dropped, then all of a sudden the arterial blood shunted over to the right side of the heart, and that's why we had that venous bright red blood happening at that time. So what happened at that point, we were getting ready to arrest the heart. The patient started to defibrillate. At that time, we were cooling. So the PA ended up kind of compressing the right atrium to kind of close off that fistula. And then we went ahead and gave retrograde cardioplegia, arrested the heart, and then the aorta was open and that fistula was visualized. And you can kind of see that here in the upper right corner where he's pulling the tissue from that fistula. So this was a left to right shunt. However, it only occurred when the pressure drop happened below 50 millimeters of mercury, something against everything that you would ever think of. I would never think of a left to right to occur at a lower pressure, especially at these high flows. There was no shunting evident when the pressure was, high 50s, or 60s or more. The patient only had a history of hypertension. There was no other history workup as he grew up, any history of any issues with lower blood pressures or testing or anything like that that would be indicative of this fistula. The thing that you have to keep in mind when you think about these patients here is, this could become a catastrophic event. Had you not recognized this color difference or you ignored it, right? So some of us are it's like, it's just a sat. So no, we're going to arrest anyway and cool the patient. But this could be detrimental to these patients. So, the other thing too is he was in that motor vehicle accidents 3 weeks prior, a couple weeks prior to this event. Had he had some internal bleeding, right, at that point in time, his blood pressure would have dropped. He would have shunted volume from his aorta over to the venous side of his body, the right side. So you would have lower cardiac output, tachycardia. He would have gone into shock and had further issues, and they would have never have known kind of what's actually causing the situation. Hypertension medication too. This guy's pretty lucky that he had severe hypertension, and yet if he was a poor dosing or treated inappropriately and his blood pressure dropped, who knows what would have happened to him. He could have expired that way. Exhaustion too. If you get physically exhausted, your blood pressure drops. And if you have somebody, I'm just tired, he could have passed out and his family wouldn't have known what would happen. Same with dehydration, as well as falling asleep, our blood pressure changes there. One thing that we don't ever think about, and we had grapefruit out there too for a drink, is some of these citrus fruits will also cause that to happen. So he could have had some of these mild events going on, or even at home, if he worked out, drank some grape juice, he could have, passed out and expired because of the shunting. So what we ended up doing is an urgent resection and placed a graft in his ascending aorta, 14 millimeter graft, and also did the innominate and carotid. We repaired the fistula as well as the aorta. We did a hypothermia and circulatory arrest on bypass, and then he also removed some adhesions there. So some considerations that we need to consider is going back to the basic fundamentals, of when we first learned about, going on bypass, watching pressures, watching color changes, feeling the arterial line when you're going on. Make sure, especially with roller pumps, you're going on and it's hard as a rock, you know. Are we occlusive? Looking at these simple things that we take for granted every day. Even in cooling, we should see some type of a color difference. Sometimes it's hard to see those color differences, especially when our venous saturations are so high. And then trending. I mean, that's what we do in perfusion is trend. So, you know, watching those pressure flows, looking at these characteristics of these patients and kind of recognizing these changes appropriately, and of course communication with the surgical team, especially the surgeon. Oops. And then here's just a picture of the color difference between that we should typically see no matter what our sats are. If we failed to figure this out, fluctuation in these pressures, you know, shunting the arterial blood to the venous side, of course, obviously decreases your cardiac output, decreases oxygen perfusion to the extremities, organs, you know, can cause further shock or complications to these patients because of the hypoperfusion. Two, if you didn't recognize this and you were going to go ahead and give cardioplegia, and we didn't have somebody kind of closing off this fistula or this shunt that's going from the aorta to the right atrium, you know, if you give antegrade, obviously you could have a big problem. And if you give retrograde, you know, and you're not appropriately pushed into the sinus or coronary sinus, or if the fistula incorporates some of that as well, you're going to have some difficulties there. And of course, surgeons, oh, why can't we arrest the heart? And can anybody think of any other situation? So the outcome of this young man, patient came off bypass. He was extubated in 6 hours. There were no issues, and he was sent home after 10 days. So the surgeon that we had, he's a phenomenal vascular, specializes in these procedures, you know, dissections and roots. So we were really lucky. He was a great guy. Do you have any questions?
Do you all use cerebral oximetry?
Yes. Yes, there were, I don't believe that there were any changes with this. I can't be 100% sure. The next one, I do have a picture of that. But you know, at that point, there was no significant changes that we were seeing at that point. Probably why? Because these were sudden changes. You're talking, you know, pressure drop, you see the shunting, we treat it immediately, pressure goes back up, you don't have the shunting going on. And so I think if you had prolonged shunting where it affected your output, so if you had, and two, it's a fistula. How much shunt is actually going over to the right side of the heart versus the rest of the body, even though you have blood pressure changes? It's minute. You're talking 10, 15 seconds, not several minutes of hypoperfusion that's going to cause cerebral vascular incident, especially in the OR. Maybe at home, you know, if you had something where it wasn't detected, it would be more evident. So.
How long you stuck?
I'm trying to think. This was like a year and a half ago. He's pretty quick. He only circ arrests for maybe, you know, 20 minutes, 20 to 30 minutes. He's a fast guy. Yeah.
So do you think that the fistula was responsive to a vasoconstriction, or that there was like a flap valve or something that with lower pressure it was open, but higher pressure was closing it?
Yeah, and I was actually talking to the surgeon in May of this year about this case, and I asked him, you know, to recall back when we did this, and, you know, he wasn't even sure either. I said, why do you know, was there a flap valve? I mean, he goes, I have no idea. You know, he didn't see anything that was evident. He thought it was one of the most strangest things that he'd never seen. A left to right shunt with a low pressure like this. Usually it's opposite. So there really wasn't any reasoning for it. I don't know. Any other questions?
One question here, was retrograde cerebral perfusion used?
No. Nope, never.
Okay, maybe not.
Yeah, so they always do TEE in the OR. There was no evidence of the fistula. And what I think, like I said, you know, normal pressure when you're in the room, normal pressure, there really probably wasn't a shunt. So they didn't see anything. It was only when the pressure dropped, you know, below 50 that you're starting to see the shunt. So there was no evidence in any of the workup.